Hello, RDs and RDs to be. Welcome to the RD Exam Ready podcast. I'm Zach Caseberg, your tutor, coach, and guide. And my biggest passion is to help RDs and RDs to be just like you to learn more about the RD exam and how you can dominate this thing. More than 1 in 7 adults suffer from this disease related to the body system. That's a real statistic. A fake statistic that I have is that 7 out of 7 RDs to be fear studying this topic. What's the answer? The renal and the renal system. Let's say you work in insurance or in farming or in a non medical related field. Do you think about your kidneys day to day? Likely not. I think undergrad and grad students sometimes treat kidneys in much the same way. You've heard me possibly many times mention that having a good root in human anatomy and physiology is what's going to be really essential for you to be able to get through some of that MNT concepts there. Today, I'd like to focus on just that anatomy and physiology of the renal system and work with you to have all the basics that you're going to need to know for your exam day. Why is kidney disease so important to RDs? Plainly put, the importance of nutrition in treatment of kidney disease can help predict things like mortality and morbidity. We can make a real difference in the nutrition status with these patients and help keep their life longer. By maintaining a good nutrition status throughout their treatment, they can live relatively normal lives with their chronic disease. Now, renal, it comes from the Latin renis, the kidneys. Your kidneys, hopefully you have both, but if not, no offense. These kidneys sit up a little bit high towards the back of your abdomen, and they exist in the peritoneum. Remember, that's that membrane which surrounds the other abdominal organs like your liver and your intestines. We can give a little list of functions of the kidney as there are a few. They filter, reabsorb, and excrete waste in the body. They will also do things like maintain the pH in the body by excreting or controlling hydrogen secretion, preserving or producing bicarbonate, our base, and by synthesizing or excreting things like ammonia, which can be an acid. A third thing it could do would be the conversion of calcidiol to calcitriol, which is the active form of vitamin D, and thus it's going to work on the stimulation to absorb more calcium in the kidneys and in the intestines. Another little point is that the kidneys can also participate in gluconeogenesis for the use of glucose in the kidneys, as well as production of glucose during periods of starvation. I want to introduce how things flow through the kidney. This can be a bit of a complex process, so I want to break it down all together here. The kidneys receive blood from the renal arteries. Remember, arteries take blood away from the heart into those other accessory organs throughout the body, right? So the renal artery is transporting blood away from the heart to the renal system. The blood goes through the kidneys, drops some stuff off, and then returns to the heart through the renal veins, right? So it goes out the artery to the kidney through the vein. Now you have that large series of just how the blood flows, but what's happening within that kidney? Let's talk a bit more. If you're watching on YouTube, Spotify, wherever, I'm hoping that I want to put up a graphic for this, but if you're just listening, I'm going to describe and you can imagine what we're going through. We're going to start with a nephron or a kidney cell. And we're going to use kind of a river analogy here that I want to try out. The arteries that are bringing that blood to the kidneys, that is the river that's flowing, this big, strong river. And the water or this blood ends up coming into the kidney and enters the glomerulus, okay? The glomerulus is this network of capillaries that are all bound together and they serve to just about absorb everything. So the glomerulus is located in like a bay or a capsule. So the water and everything comes into that bay. We'll call this bay or this capsule the Bowman's capsule. As the blood is in the glomerulus, we are then absorbing things like our byproducts of metabolism. So within that glomerulus, with that capillary network, you're taking and pulling things out of the blood like nitrogen, hydrogen, ammonia, bicarb. glucose, amino acids, fats, electrolytes, minerals, all types of things are coming out of this during this point. Then we're just returning that clean blood back to the heart after that. With those byproducts that we just talked about, we are going to absorb them and they are going to go from the glomerulus to the renal tube. Okay. The renal tube is going to be where it's going to transport this stuff. And we're still within the nephron here. Now we're beginning to form urine in this process. But before we take that urine, we have this ability, this one more chance or so, to reabsorb some of those byproducts. Once the kind of those byproducts are in that renal tube, we have this potential to reabsorb things should we need to. That's kind of what the process is. The body can regulate and change and say, I need to reabsorb these things. So we'll have that opportunity to do so. There's this long loop that's called the loop of Henle, and it joins with a larger duct or a river to carry that urine out into collecting ducts. These collecting ducts hold the urine, they merge together, and eventually form the ureter to take urine from the kidneys to be stored in the bladder. So that's kind of a long process to go through of how it comes from the blood and get exits the body. A few notes I want to make along that path that are relevant to the exam. Remember, as I said, the glomerulus is a bunch of capillaries all bunched together, and they're ready to take that byproduct out of the blood. Glomerulus should remind you of the glomerular filtration rate. I'm going to do that a couple times today, so get ready for it. The glomerular filtration rate is how quickly the nephron is able to remove these byproducts out of the blood. Okay. In people with CKD, their glomerular filtration rate is low, but in healthy kidneys, it's generally high, which is a good thing. This shows you where we get this glomerulus and how the glomerular filtration rate, or the GFR, factors in. Know that a lot of the times with diseases that impact the blood vessels, such as diabetes or high blood pressure, this glomerulus is being damaged as well because they're all just little blood vessels, right? So, this is why diabetes in particular leads to damage of those arteries and thus can lead to CKD very commonly. So, we want to maintain that normal GFR, which you should know as being about 125 to 130 milliliters per minute going through that nephron. Fascinating, right? Our kidneys definitely love to excrete, don't get me wrong, but I don't want you to think that that's all that they do. The kidneys also absorb much of the electrolytes, glucose, amino acids, bicarb, phosphates, and water that they're responsible for filtering out. The second major function that I wanted to come back to was how the kidney is regulating pH throughout the body. This can be a little bit complex and can be a bigger conversation just about, the whole process of acidosis, alkalosis, and compensatory factors. But I just want to tell you about the physiology of what the kidney's doing and how it's doing it. If you needed an immediate adjustment to your pH, what I would recommend is you rely on your lungs. The lungs are going to be much faster than your kidneys to regulate pH in the body. But the kidneys can progressively also maintain this pH status. Remember, you have acid in your body, which is your hydrogen ions, your ammonia, and you also have your base in your body, which is bicarbonate. The kidneys maintain the pH by secreting out those hydrogen ions and conserving the bicarb, and also doing some things to also either excrete ammonia or make something out of it. So, to talk about those hydrogen ions that are kind of just free floating, these are pretty quickly removed and they can be used for things, but if we want to, we can just quickly remove them out of the body, excrete them through urine. So if we have a lot of hydrogen or a lot of acid, we can go ahead and start ditching those and excreting those to help balance our pH. We could also use those hydrogen ions to make bicarb too. That's what we would probably start with is you can use those hydrogens to help you to make bicarb, and now you're producing more base out of those leftover hydrogens. Ammonia, or an acid, also has the ability to bind with some of those hydrogen ions to form ammonium ions, and these will also just be excreted through urine. Now, bicarb, being the big critical base here, can be regenerated in the kidney through several of these byproducts that we're talking about. So, if there's any reason we need more base in our blood, we can simply tell our kidneys, make more bicarb, and they should readily be able to do that to help to adjust our pH and maybe bring it up a little bit here. The RAAS system is one lesson we're going to kind of finish on a little bit here before we do our PQs today. We need to talk about the renin-angiotensin-aldosterone system, aka the RAAS system. This is used specifically for the maintenance of water and sodium chloride throughout the body. The RAAS system activates when our extracellular fluid is low. This will be times when my blood pressure is low. Maybe I've lost a lot of blood, or I don't have a lot of fluid throughout my body, or I'm dehydrated. These are reasons why the RAAS system activates, is when we need to retain more water and sodium. I want to introduce each piece of this and then add it to the story of how the RAAS system works together. We're going to start with renin, okay? Renin is a hormone of the kidneys, and it is released when blood pressure is low. Renin has the responsibility to start a series of reactions, including the hydrolysis of angiotensinogen to its other byproducts, and this also helps result in later the release of aldosterone. So, to help you to start, renin is kind of like the starting signal hormone that tells everyone else to start moving. Okay. Angiotensinogen is an inactive enzyme that is released by the liver into blood. Okay. Similar to pepsinogen in the stomach, it's an inactive enzyme. Renin will come in and convert angiotensinogen to become what is known as angiotensin 1. Angiotensin 1 is also inactive, if you can believe it. Angiotensin 1 is converted to angiotensin 2, and that's the active form of this enzyme. The thing that converts it is actually a thing called ACE. ACE is going to stand for the angiotensin converting enzyme, and ACE is what comes in to say, angiotensin 1, you need to become angiotensin 2. Okay, that's a lot to go through. I bring up the ACE part because I want you to think of ACE inhibitors. ACE inhibitors are very common medications used to lower someone's blood pressure. So you can kind of see this connect here of the RAAS system in saying that, okay, ACE is the enzyme responsible to tell angiotensin 1 to go to 2. This is what's increasing my blood pressure. So if I take an ACE inhibitor, the goal is to prevent that from happening and keep my blood pressure low. Now, angiotensin 2, it does a few major things. One, it does vasoconstriction. It takes your blood vessel and constricts it to make it smaller. This is going to increase your blood pressure. Angiotensin 2 will also increase your thirst center, telling you to drink more water. It'll stimulate vasopressin. Vasopressin will result in the increase of water resorption in the kidneys. And it's also going to reduce your GFR because what it's saying is it's saying, hey, glomerulus, we don't want you to remove all of this sodium, all of this water so quickly. We would actually rather you hold on to it. So angiotensin 2 is telling the glomerulus, hey, stop filtering so fast. Let's go a little bit slower so we hold on to things. A major thing it'll do is also signal the release of aldosterone. So to tell you the story to this point, we've had renin, which activated angiotensin to become angiotensin 1. Then ACE came in to tell angiotensin 1 to become angiotensin 2. Now, angiotensin 2 is signaling the release of aldosterone, the next player in our story. What aldosterone will do is it's going to promote the reabsorption of sodium and the excretion of potassium in the distal tube. Water follows that sodium resorption. So, to kind of summarize that, aldosterone is saying, hey, body, hey, kidneys, reabsorb more sodium, reabsorb more water, do all these other things together. And in doing so, my blood pressure will go up as a result. Whew. Now that you have this base, I think we're ready to apply it to practice questions for your exam day. I want you to use our PO, our process of elimination, and use A, B, C, and D for each answer to help solve which the best one is. Let's start with number one here first. A healthy glomerular filtration rate is A, greater than 125 milliliters per minute, B, 90 to 70 milliliters per minute, C, 60 to 90 milliliters per minute, or D, 30 to 60 milliliters per minute. A healthy glomerular filtration rate is greater than 125, 90 to 70, 60 to 90, or 30 to 60. I'm going to write A, B, C, and D. As I go through each answer, I'm going to say, hey, do I like it? Do I dislike it? Or maybe I'm just questionable about it. Starting with A, greater than 125 milliliters per minute. I think that this is a good answer for me. I know that around 125, 130, I know I wanted it to be. 125 is a good reference number for me. I like answer A, and I'm going to hold on to it. For B, 90 to 70. Well, 90, I know that's a pretty okay GFR. It's not like you're really in CKD with that. But once you get down to 70, we're seeing lower GFR and definitely not a healthy GFR at this level. So I would say B is a bad answer, and I'm going to get rid of B. C and D are going to go similar to B. 60 to 90 milliliters per minute. This is starting to get kind of on the low side of what GFR should be. In 30 to 60 milliliters per minute, we're starting to get in some later stages of CKD at that phase. Therefore, I think I would get rid of B, C, and D for a best answer of greater than 125 milliliters per minute, or answer A. Number two, which of the following does not occur as a result of angiotensin 2? Which of the following does not occur as a result of angiotensin 2? Is it A, increase in blood pressure, B, release of aldosterone, C, increased GFR, or D, increased thirst sensation? So make a point for yourself. You're trying to remember what applies to angiotensin 2, but remember, you're looking for what the not is, so look for the odd one out. Starting with A, increase in blood pressure. To me, this is going to be a result of angiotensin 2. I don't think A is my best answer because I'm looking for the not. I know that the RAAS system altogether is trying to increase blood pressure. So that's got to be an okay one that I'm going to remove for this one. B, release of aldosterone. Well, that is going to be a result of angiotensin 2, along with several other things, but release of aldosterone was one other effect that is going to occur. So I'm going to get rid of B. C, increased GFR. Okay, I'm going to put a question mark by that one. Or D, increase in thirst sensation. So between C and D, I have our increased GFR or D, increased in thirst sensation. I feel like we would have an increase in thirst sensation as a result of angiotensin 2. Because angiotensin 2 is kind of telling the whole system of, hey, get the blood pressure up. So that being said, I would get rid of D. And if I was to look at C, my best answer for increased GFR, this makes sense to me because the aldosterone 2 is telling the glomerulus and saying, hey, we don't want you to be going fast. We want you to be going slow. So angiotensin 2 would actually cause a decreased GFR instead of an increased GFR, making C my best answer here. Number three, the interconnected capillaries located in Bowman's capsule of the nephron is known as the A. Glomerulus, B. The renal tube, C. The collecting ducts, or D. The loop of Henle. The interconnected capillaries located in Bowman's capsule of the nephron is known as the glomerulus, the renal tube, the collecting tube ducts, or D. The loop of Henle. A, B, C, and D for each of these. Starting with A, the glomerulus. Okay, I remember the glomerulus is kind of this spaghetti looking, kind of connected area where all of the absorption and removal of those byproducts occurs. I feel like A, glomerulus might be a good answer here, and I'm going to put a check mark by it. B, the renal tube, the renal tubule, excuse me. That's not going to be the interconnected capillaries in the Bowman's capsule, but the renal tubule will be where the byproducts end up once they've gone through Bowman's capsule. So I don't think it's B. C, the collecting ducts. Well, the collecting ducts are just collecting the urine, and they're much later on in this phase. I don't think we're talking about the Bowman's capsule. I think we're much past this. I would get rid of C. And D, the loop of Henle. The loop of Henle is connected to the renal tubule, which is where those byproducts are headed to as well. I think I'm going to stick with answer A. My glomerulus will be my best answer for the interconnected capillaries located in Bowman's capsule of the nephron. That's a wrap for today's lesson, students. I hope you've listened, learned, and enjoyed kind of listening in with us during today. Remember, passing this exam is always a journey, and I want to be here to assist you and other students you know. So do me a favor, subscribe, and let other students who you know are studying know about this show, just so I can assist them with passing the exam and bringing the next big group of RDs into the workforce. Thank you for always listening and supporting, and as always, happy studying, RD to be.